It depends on where you're at. You can't come over here in between me for sure. So there you go. So we're gonna go there. Oh, close. This one came with a needle. So when we do this, and we're gonna practice opening stuff again. When you do it, you don't want to be too gentle. If you throw it too hard, especially with wires, they're in that plastic sheath. They'll bounce right off your table. So those you have to be a little bit careful with, or let somebody actually grab it. With this kind of stuff, you kind of open it and kind of pop it out. You kind of pop it out of the package, or it tends to stick. Because some of this stuff's rubbery, right? So I get my sheath. This one had a needle on it, so I'm going to take that needle. I don't need it. I'm going to get it out of my way. It's just an access needle. It's another 18 gauge needle. This, if you threw this away, you would have lost your little introducer. They're all set up a little bit differently. I'm going to take my wire here. This is a straight wire, which I don't really want, but it's fine. Whatever it is, you just make sure you put that thing on the end. Is all we're worried about. Now that's going to slide. This is a smaller 4-French sheath. Have to go over an 035 wire versus some like 5/6. All the other ones can go over an 038 wire, the diameter wise. So the 4-French though have to do 035. So this, I really don't need this. So technically, if you want to get rid of it, throw it in the trash, get it out of your way, whatever. Just don't throw it on the floor. My cap, I'm going to take off, but I'm going to keep it. I'm going to go ahead and take this apart. Some people will flush it like that with it in there, but it doesn't really get this part flushed out good. So I'm going to take it apart. I'm going to take that's a little curvy, but that's fine. You can kind of straighten them out sometimes. I'm going to flush, and I'm going to go ahead and flush into my waste bowl. Right? So I'm going to flush into my waste bowl. Even though it's just heparin, it's not bloody, it still weighs. So I'm going to flush. Again, this is labeled saline. I'm going to flush. I'm going to hook up to my sidearm, whatever you want to call it. I'm going to flush again here. So don't put your hand over this so you can't see. You want to watch for bubbles. So I want to make sure I'm doing my angles. Even if my arm doesn't have to be at an angle, but my syringe should be at an angle, at 30 to 45 degrees. Pretty much everything we do is 30 to 45 degrees, almost everything. So I'm going to flush. I'm looking for bubbles. I can kind of tap on this thing a little bit if I need to. Flush, flush, flush. Looks pretty good. And then, which way am I going to turn this?
Towards the gap.
Toward the sidearm. Again, the wording thing, if you put it on a test, I'm going to try to get a picture because it just makes more sense. Toward the sidearm, because it's like you're plugging that sidearm up, so blood's not going to come out. Come over here. Let me go ahead and go here and put it together. All of them snap. They're just a little bit different, but they should kind of, you can feel it. You can't hear it, but yeah, you can feel it. And then, since I'm going to go ahead and have some saline in here, I'm going to pretend I had some saline in here. I had a wet one here. I'm going to go ahead and, since this is going to go inside the body, as far as inside the actual artery, I'm going to wipe this down just to make sure. There could be a little piece of plastic that got bent or caught on something, and so it might be rough. We don't want that, so we're gonna wipe it down. Either way, we're gonna wipe it down. Should probably go ahead and wipe this wire down too, just so we know that we don't have any defects. Just in case, so you can wipe it down and then put this thing back on. So you wiped it down, Our needle that we're gonna stick with, you can go ahead and take this off if you want to. Your little cover, your sheath for it, and then we're gonna go ahead and pretend I have some fluid here. We're gonna go ahead and flush it out. You can flush it out technically you could flush it out with lidocaine. It's just to make sure there's nothing in it, because lidocaine is what's gonna go through it if you have to give some more through it. But you can do it with flush too. If you just flush everything out at once, that's fine too. But technically, since we're gonna stick this in the body, it's not going in the vessels, but you could wipe this down. I probably wouldn't know because it's sharp. It's pretty sharp on the end, and that bevel is big enough to where you could, if I did this hard enough and just went this way, it would cut my glove and cut my finger. So I probably wouldn't worry about that part. But I would flush it out. We'll say flush it out. So flush our needle, wipe and flush our sheath. Okay. So what size is this one? Red. 4 French. Okay. And then so remember, so this is what this wire. I don't know if everybody can get a wire to use. But this wire's a little bit floppier. It's because it's an 035 instead, because it has the lumen of this dilator is smaller because it's a 4 French. It's the smallest one we really use. So 5 French, that hole's big enough, but it won't work. Like an 038 wire, you cannot use with this because if this was in the bottom, right? So we put this in, and this was an 038 wire. When I go to put this sheath on, it will not go because that wire's too big to fit to this dilator. keeping this all in track. So I wipe my wire down, I flushed and wiped my sheath, and I'm gonna wipe my, just flush my needle. We're just gonna say flush the needle. So this part, I mean, I'd say that's done, right? I mean, I can't think of anything else to do. Checking all of our expiration dates, then I could drape. So let's pretend like this was my bowl, and we're gonna have it set up just like that, like we used to the other day. So just like these blue bowls, pretty much, or it's one of these, it kind of depends. There's the styrofoam on top of it, and you can kind of see, like I took one out to make a table on this one right behind Alyssa, straight behind. So it's just on there with that styrofoam. That's what you're sticking through. That's what you're kind of numbing in. Now the numbing part's kind of hard to do in the styrofoam because it doesn't really soak it up, so it just kind of pushes out. And when you aspirate, you pull a lot of air. That's fine as long as you aspirate before you eject, because that part, like right now, I'm looking for bubbles. Because you haven't done anything, you just filled your syringes up, and you should always be looking for bubbles and making sure no bubbles there. But when you go to use that part and you pull, you aspirate, you're sticking, if you get bubbles, air, that's just part of it, you're going to. But you still can try to tap on your syringe a little bit, you still keep your angles to keep the bubbles up. So then, I'm done here, I'm gonna turn around, you're gonna go ahead on this one and you're gonna pull this off, right? So we're actually gonna use the stick because you're gonna be done with your drape. So you can pull it off. Yeah, we'll probably just have a reading sticker. So that way, whenever we open the drape up, it doesn't move on you. It's more realistic, because whenever you're practicing, you go to pull and everything, and it just all slides. It doesn't really feel the way it's supposed to be. So we'll pull that off, go here. Julie and I will be on the other side to help you. And so we'll have another table behind you, either a table, bed, probably one of the mannequins, just to make it more realistic. So you would open the drape up. But I skipped a part. So before I did that, what's two things I'm gonna do?
3 towels?
Okay, what are 3 things I'm gonna do? So
Check
one,
to see if the patient was prepped already?
first, were they prepped? Because you can tell in real life if they were prepped. You can see it, you're paying attention, you're watching, but what if you're in a hurry, somebody else is in a hurry, your monitor tech, again, I'm gonna do this, but don't do that. You wanna ask for sure, did you prep? Yep, it's done. We may even just kind of act like we do it, right? So we're at that point, 3 towels. I'm gonna take 3 towels. You can take all 3 at one time and just kind of, you keep things with your fingers. You don't want to necessarily do this because then you're turning around 3 times. So grab all 3 of them. You're gonna open one up. I'm gonna go here. And I'm gonna make sure I don't touch anything over here. I may have there, but we'll pretend I didn't. I'm gonna go here. And I'm gonna go here. So now this is the groin. Again, we'll have the dummies, our mannequins set up. Or I shouldn't say dummies anymore, it's probably not nice, but the mannequins will be set up with their groin this way. So one thing you can do is whenever you have this, you can always kind of push, because these are towels are sterile, so you can touch a little bit, but you don't want to go, so let's say this towel was too far this way. So whenever I prep the patient, I'm going to put a towel down there, a non-sterile towel, just to keep them covered, just to leave some dignity as much as we can, keep them covered up. So there would have been a towel there. We usually don't use the blue towels. Usually they're a little bit different color, hopefully, so that we don't get confused, but they very well could be all blue, so you just have to be careful. It's just going to be one down kind of the middle or to the side. So if I put this towel over too far this way, let's say the non-sterile towel was right here, I can't really take this towel now and pull it back over this way. It's kind of done. So I could take a new towel and just do it again if I didn't put it in the right spot. So I'm just going to do this, and I'm going to cover this one. I can push that one over. Now I'm still good. Does that make sense? Okay. So this is ready. So you're going to check for prep. Then I'm going to grab this thing, my drape, this thing. You grab my drape, fold. Now before I do this, a couple things. You're going to learn where this fenestration goes eventually. A lot of people will feel for the pulse first, then put it down. What usually happens is if you do that and you put the drape down and it's not quite where you want it anyway, so you kind of have to pop the drape up anyway. So I would say we're going to peel. I'm going to take this side, I'm going to take this side here. So you can see I'm kind of grabbing, I can grab this whole part if I need to. I'm going to throw it this way. That's going to be Julie or me over there helping you. And then you're going to pull this side, come here. We all use, I don't have help, and it's fine, but you all know how to do this part, I think. The draping part's not that big a deal. It'll be a lot easier when it sticks. One thing, I don't know if you noticed whenever I did this, I saw a lot of people doing this with their left hand that they're not using. You don't want to put your hand down below ever. So always keep your hand up. So whenever I put the drape down here, I'm just maybe even kind of thinking, because I'm sterile here to here. So even if you think about it, put it on your, if you have a problem with it, put your hand on your stomach, or you know what I'm saying, somewhere in there, like not up here by your neck, but kind of in your midsection. Just touch yourself on your stomach if you have to. That way you try to remember. Then eventually, you know, if you do this, that's fine. But this is what we really want to do. You don't want to do this ever. When we're standing there waiting on something, we don't want to do this. We're always here. We're even here like this. We can kind of cross our hands like this. We can't do this technically. I don't know how many times I've done this, but you're not really supposed to do this because our pits aren't necessarily sterile, right? We're just sterile here to here, 2 inches above our elbows to our fingertips, and that's really all we're considered sterile. Okay, so we're gonna open our drape. I can have probably some extra towels for you because it's just kind of more normal. So what we would do here is once my drape was open, so my drape's open here, I would take, I'm gonna go ahead and take one more towel. Real life, we might use 2 or 3, and I'm gonna put one down here like this. Just because I can see things a little bit better, I'm gonna put my syringes on top. I'm gonna put some 4x4s over here, right? So can I get you all to scoot out and I'll just show you. It's gonna be a little bit different because your table's not gonna be quite like this. Well, actually, if we have the mannequin on there, it will be. We just don't have a million towels, right? So I would put one towel down, then I'm grabbing my sharps, my lidocaine. I'm gonna take a few 4x4s. In real life, you don't have to do this for the checkoff, but I'm gonna do something like this. Because now, whenever we go to stick, sometimes people just bleed. Sometimes people are already on medications that might make them bleed a little bit easier. We put too much lidocaine, it gets kind of pushed back out. Then they're kind of bleeding in, it's kind of wetter because it's got lidocaine in it. So we can use these 4x4s, and we just we're dabbing, we're kind of cleaning, keeping things clean. That's what they're there for. So then we're gonna stick. Again, I don't think we're gonna be soft enough to actually do it. We're gonna use, we can do 2 different things. We can drape on the mannequin to make it more realistic, like where we're going. But then we're gonna stick on those styrofoam things. So we may just have that set up separately on a separate table. And what you're gonna do then is do our stick. We're gonna do our numbing, we're gonna do our stick. So let's pretend that I'm covered here. This is my other table. Like this. This is my groin. That groin, right? So I'm here. What's the first thing I'm gonna do?
Check for pulse.
So I'm sticking now. So it's time to stick. Check the pulse. But before I do that, I'm gonna tell them I'm gonna feel for the pulse. This is about the time when people if they're not all the way out, they'll jump off the table if you push on them too hard. So we're gonna say, we'll give you a name, Smith, whatever, Mr., Mrs. Smith, Mr. So-and-so. It doesn't matter as long as you know that you're supposed to say something and you do it. Hey, Mr. Smith, I'm gonna feel, and I usually in real life, so patient's head, so this is our groin, patient's feet, patient's head. I usually wiggle my fingers because a lot of people, they're old. A lot of people are 60, 70, 80 years old that come to the cath lab. Most of the people you see are old. They can't hear a lot of times just because that's what happens when you get old. So I'll even tell them, and they usually take their hearing, sometimes they'll take their hearing aids out. Do they take their hearing aids out a lot of times? So you have to yell. They can't see our lips because we're covered up, right? And so I'm gonna tell them, hey, I'm gonna feel for your pulse. Mr., Mrs. Smith. It's better if you call them by their name because that way they know you're kind of paying attention to what's going on. I'm gonna feel for your pulse. I'm just gonna push on you with my fingers here, right? So I'm gonna push, I'm gonna feel for the pulse. We're just pretending, but feeling for the pulse, okay? Obviously it needs to be somewhere in that realm of where we think about where the pulse is gonna be. You don't want to, if we have the bowls here and we're considering this like our crease and all that stuff, you don't wanna stick over here, right? That's not gonna work. So this is our bowl. It's got our red fluid in it. It's going to be our blood. We've got our styrofoam skin layer that we're going to use. And so I'm going to feel for the pulse. I found the pulse. You can leave your fingers on so you don't lose the pulse. You just have to be careful whenever you go to stick that you don't stick yourself because people will do that. So we're going to feel for our pulse. So again, usually if we have our crease here, we might ask you something like this. If our crease is here, we're usually going 1 to 2 centimeters above that. 1 centimeter is about the width of your finger. A couple people might have little fingers, it might not be quite that much. So 1 or 2 finger breadths or so is about where you normally are going to go. 1's good enough though for what we're doing. But we feel for our pulse. I'm going to go ahead with my needle. I'm going to go ahead and push a little lidocaine out through that needle just to make sure. Just put it in our waste bowl. Let's go ahead and be official. And we're going to put it in our waste bowl, which is down here. But we're going to waste into that just to make sure the needle's not bent or the needle's not, that actually has a lumen. I mean, you never know if there was a manufacturing defect or something. So we're going to make sure that we go through there or push through, flush it out. Then our bevel, we're always looking for our bevel. So bevel up. We're feeling for our pulse. If you let go, that's fine. It's not like an official thing. Feel for your pulse. Just make sure you feel for it again if you let up. Then I'm going to come here. I'm going to say, okay, Mr. So-and-so, Mr. Smith, you're going to feel a stick and a burn. You're going to numb your leg up here. You can even tell them that first. It's fine if you just say stick and a burn. But all right, Mr. Smith, Mrs. Smith, I'm going to numb your leg up here. You're going to feel a stick and a burn. Stick. What do we do before we push anything in?
Aspirate.
Aspirate first, make sure we're not in a blood vessel. And we're just going right below the skin on this first one. So I'm aspirating, no blood. I'm going to push, right? And we're not going to push a whole lot of lidocaine. We're just pretending because that styrofoam does not soak it up and you're just going to end up getting a lot of air. But so we do this right under the skin. Then we're going to go even a little bit deeper with it if we want to. Aspirate again. We're going to inject. And if you don't want to try to push anything through that styrofoam because you really can't and that needle's not going to go all the way through it, you can just say, I'm going to push. You can still aspirate in real life, right? Because you're just going to pull air. Aspirate, I'm going to aspirate, and I'm going to push. You don't have to actually push if you don't want to because you're not actually going to be able to push it in. And if it feels funny or whatever, just pretend like I'm pushing like. Okay, that one's done. Again, this is up on my table. I'm in order, left to right, how I'm going to use them because that's just how we do it. I'm going to go here. So I've got my, which needle now? 22, we're 21. It just depends. You might see 21. Again, I'm going to kind of check my tightness of my needle on the hub of that thing. You don't want it so loose that whenever you push anything out, it's going to pop off. But you don't want it so tight that you can't necessarily get it off without something. I know everybody wants to put them on too tight most of the time. If you get them on too tight, use this thing. Use your hemostats, your Kellys to get it off. Because what will happen is, if it's the doctor doing it, what they'll do is they'll numb with this second one. They might want another syringe full even. And if they go to try to take this thing off and they can't do it, they're going to be like, get that needle off of there. Or what, it just depends on who it is, of course. But they're going to expect you to end up doing it because you put it on there a little bit too tight. So either way, we're here. Again, I'm going bevel up. One thing, I already know where I poked in real life because I can see it. This you can't tell as much. I can see a little bitty hole. I can see where some of that lidocaine's coming out, so I can see what I'm doing. But I'm still going to feel for the pulse. All right, Mr. Smith, you're going to feel a little bit deeper burn here. I'm going to go in that same spot, and then I'm going, again, my arm doesn't have to be at an angle, but the syringe needs to be at that 30 to 45 degree angle. So again, you've got 90, right? So 0, 90, 45. So you really don't want to do anything more than that, or less than probably, kind of in between there, basically. So 30 to 45 is our angle that we use. And it's really, I'd go just a little bit above 30, because if you start doing 45, you're starting to be where you're going to end up hitting in that back wall of an artery or something, and things just don't bounce off. And right, so we're kind of going as coaxial as we can. Coaxially as in like we're going the same direction, right? So, all right, Mr. Smith, deeper burn here, stick. And when we do this one, I'm just going to go all the way in. Boom. Then I'm going to aspirate, because it's better to go all the way down and numb on your way back out than it is to stick. So if you stick here, right under where we just numbed, and I inject, and it numbs that up. Okay, if it infiltrates down in there, great. But if not, I'm sticking deeper, guess what? It's going to hurt again. The pokey part's going to hurt again, right? The needle point's going to hurt again. So if we just go all the way through, bevel up, angle, deeper stick here, you might feel a little stick. Boom. First thing I'm going to do is what? Aspirate. Because this needle, you might hit the artery sometimes. You have to be careful with it because it will go in. So if I aspirate, and I see some blood, and you're not going to on this one because it's technically not long enough to go through everything that we have. But I may say, oh, you got some blood. So what are you going to do if you have blood? You aspirate? You're just going to pull back a little bit. And you can kind of aspirate as you pull back, or you can just pull back. What am I going to do then if I pull back?
Aspirate again.
You're gonna aspirate again because you still don't know if you're in that artery or not, or if you're in another little artery. So I'm gonna aspirate some more. Okay, we're good. Again, you don't have to necessarily push anything in, but you want to tell me that I'm injecting, or it's pretending I'm injecting. You can say it, you verbalize it if you want to, because it's not gonna be able to push in. This one might go through the styrofoam, and you can technically push the water or whatever's in there in that bowl, and that's fine too. So that one's done. Then I've got which one? What are the two numbers that go with this? What's the gauge?
18.
And what's the length?
7 centimeters.
7 centimeters. So again, I'm going to go bevel up. I'm going to feel for my pulse. I know where I'm going. Again, I can go in that same place I just went. I'm going to go right along that same track. That's why when I numbed it with this needle, I kind of went more like probably at this angle, right? And then when we get past this point, that artery ought to be there somewhere. Artery or vein ought to be in there somewhere. So hopefully that lidocaine infiltrated down in there. It goes down that fatty tissue, all that skin tissue, and numbs it up. So then again, I'm always bevel up. Bevel up, bevel up, bevel up. So I'm going to feel for my pulse. Okay, Mr. Smith. I'm going to push on you again, whatever. I mean, we've already told them that we're pushing on. They should probably know by then, but you can always tell. It's always good to tell. I'm going to stick it in. Okay, Mr. Smith, you might feel, if you feel something, let me know, because I can put some more numbing medicine or whatever. However you want to say it. Let me know if you feel any pain in your leg. However, something to let them know that they might feel a little something, and that you can fix it, hopefully, if they need it. So one thing, if we're pretending this is our groin, this is like the middle of our bed, I'm not going this direction, right? Because if I'm going this direction, I'm going up toward your clavicle. If we think about the way our arteries are in our legs, our arteries go this way, and then they go up this way, and then they go to your aorta, which is pretty much in the middle of your body. So we're going to go toward, what's our landmark that we're going toward when we're sticking?
Umbilicus.
Your belly button. That's kind of what we're shooting for, because that's the way everything goes. So here, my main point is, you're not going straight. You're not going to stick in here and go straight up this way. We're sticking and we're going at an angle toward the umbilicus, fancy word, belly button. All right. So we're going to stick. So, okay, Mr. Smith, you don't have to tell them you're getting access, because sometimes they might start asking you too many questions, and you don't want to keep them awake or keep them, too conscious, because we want them to be comfortable and not be worried about it too much. But if you feel something in your leg, let me know. That's good enough. So I'm going to stick. So you're going to stick, and then I'm just going to probably tell you, okay, you have dark blood. Okay, so what you want to do, you don't want to necessarily stick and like push and what. Once you get a certain distance, I'm going to say, okay, you have dark blood. So what if we have darker blood, non-pulsatile dark blood? What does that mean?
You're in the vein.
We're in a vein, because the vein is not as oxygenated, so there's the hemoglobins aren't as saturated with oxygen. So it's not blue, but it's like maroon. Is really what's really dark red. So that pressure is like 5, right? So just like when we get to our right heart, our pressures are lower. The pressure's nowhere near as high as our arterial pressure. So you can't really feel it as much. You can't really feel your vein with your fingers, and the blood's just going to kind of dribble out. Sometimes even if they have really high pressures, it's still just barely. It might actually dribble out. Normally it's just going to kind of drip, drip, drip. Okay. So what would I do if I hit the vein? If I told you you had dark blood, first thing you're going to do is pull the needle back. I don't know if there's an official word. You're not really aspirating, right? But you're going to pull the needle back, and then so you don't just move over either direction, because that needle is sharp. They're supposed to be sharp, so they go into that artery or vein. You can slice the whole artery open, and then that's not going to fix itself more than likely. That's probably like surgical, so opening it up, sewing it up. So we're going to pull back, and then which way am I going to go? Lateral. So we're going to be fancy. Use our med terms, our cath lab terms on that, and we're going to go more lateral, right? So all you would do is you'd pull back. You don't pull all the way out, because then you might have to stick them in, like make a new skin spot. Now, if you're too medial in the first place, you might want to go ahead and pull all the way out, and then maybe even numb up a new spot or something. It kind of just depends. Again, I don't know how much you're going to get to do this. It's just so we know how it works. But either way, if we saw the doctor, whoever stick, we have some dark blood, they're going to pull back. We're going to go more lateral. We're going to go forward. Boom, and then I'm going to say, okay, you have pulsatile blood flow. You have arterial blood spurt. Kind of the way we would say it. We're here. You got your fingers on the hub. We've got our ankle. We're not like this. That's 90. That's too much. 45 even sometimes is technically too much. So the 30 to 45, we're at this angle, hopefully we're not this way, we're kind of this way. I'm gonna lock the needle in place here. I'm gonna have my wire closer to where, so that's one thing, you wanna make sure you have all your stuff up here close to you whenever you do this. You don't wanna have your wire back behind you in your sheath, you wanna have it all kind of right here in front of you. Put that needle there. So this needle, or this wire is straight, so I'm not gonna worry about that thing being on there. I'm gonna go here. So again, I'm not going all the way, this is hitting the bowl, so it's trying to bounce back at me. So I'm gonna go here, I'm gonna pull back, but as soon as I can get wire in my left hand, where I'm locking the needle in place in the first place, so the needle's here, I'm locking it in place so it's not moving around inside that artery. I'm in. I'm gonna pull back, and I can even with my, eventually you can kind of learn how to use your fingers to, just the back of your fingers to push things in. You don't have to worry about that right now. I'm gonna lock this wire with this finger. So what happens is a lot of people start doing this kind of stuff. It's the same thing whenever we use the big wires and the catheters. You go to pull a wire out, you go to pull a catheter back or whatever, and it kind of holds onto it because these things are all, the diameters are close, they're made to all work pretty close together. And you pull everything out. You don't want to do that, especially if you just got arterial access, you wouldn't want to pull that out. So we're going to make sure we lock this one here, lock this in. I'm going to keep up with my sharps. I'm not going to worry about that right now, I'm going to keep my sharps here. I'm going to have my sheath over here somewhere closer. I'll have this set up so this bowl will actually be up here, more like where you're going to be, and you'll have room down here, which it would be like more in real life. Our setup was a little bit off before, but we'll fix it to where it's more like it would be. So you can put a towel down here. You can put, so when you drape, you can just practice the drape part, and then you can do your bowl and, actually we'll probably won't have you drape this part. This part will probably be ready for you. But I'll have it ready for you so you can have room over here to your right to put your stuff. But if you have to ask for it, like if you're over here and you can't really do it, you really shouldn't let up. I just lost my wire, but you really can't just walk off, right? So that's something you want to kind of make sure that you did. So I'm in. So I'm in here. I'm gonna, easiest way to use this finger, kind of push it down. I'm gonna have some room over here. If I didn't, I'm just kind of using my fingers as a background, trying to get some depth perception here. See, this wire is really small, and the hole in this dilator is really small, so it's kind of hard to get on there sometimes. So here I have some wire, so I'm okay. I can get this thing out of my way. I'm gonna twist, just back and forth, just like this. I'm not gonna spin it. I'm just gonna back and forth, just to make sure it doesn't catch on that artery and just rip it forward. When we do that back and forth motion, it helps kind of pull it off there if it is trying to catch on the inside of that artery. So we're in. Then I'm gonna pop this dilator and pull my wire and my sheath back at the same time. Get those out of my way, and I flush my sheath out. So I don't have anything in here, but if I had my sheath, so I would take my, so what syringe am I gonna pick up first?
You're empty.
Which one?
The empty one?
So I have slip tip and I have lure locks.
Oh, slip tip.
We're gonna do slip tips on all this for this. So you can have one that has nothing in it. It doesn't really matter for this part. I wouldn't use one that had 8 cc's because then you're just gonna have a full bloody syringe. So even if you had one full, I would either waste it or I would just get the one that doesn't have anything in it. I'm gonna hook up. That's not gonna happen hopefully. I'm gonna open my sidearm, whatever you want to call it. I'm gonna aspirate. Again, I'm still doing my angles. I'm gonna aspirate. I'm gonna make sure there's no, hopefully these will get down in there. We'll make sure they're really full so they'll actually get some fluid. You're gonna aspirate, shut it off. You're gonna just